Welcome to the Deep Dive Ortho. We're all about unpacking the complex topics in orthopedic surgery, offering you crucial insights and hopefully some practical knowledge too. Today we're embarking on a really fascinating exploration of one of the most intricate joints in the human body, the elbow. Its sophisticated structure, its function, they're absolutely fundamental to how the upper limb works, and critically for understanding and treating its many pathologies. What I always find remarkable is its ability to be incredibly stable for weight bearing, yet also allow for such fine dexterity. And joining me to navigate this complexity is an eminent figure in orthopedic surgery. It's a real privilege to have you with us today to unravel the elbow's secrets.
Thank you. It's a genuine pleasure, actually, to delve into such an important area. The elbow truly is a marvel of engineering. It's a testament to the body's incredible design, really.
Yeah.
And a joint that keeps surprising us as our understanding evolves.
Indeed. So our mission today is to uncover the key anatomical features, the biomechanical principles that govern the elbow, hopefully helping you grasp why a detailed understanding is just paramount for effective clinical practice and surgical success. We'll be discussing how recent advancements, how our understanding has significantly improved things like surgical reconstruction and fracture fixation outcomes, moving us beyond some traditional approaches. So what does this all mean for your clinical practice and for your patients? Let's unpack this. So the elbow is often described as complex. Could you start by painting a picture of its fundamental structure, particularly how those three main articulations fit together in one joint? Because it's not just a simple hinge, is it?
Absolutely not. No, that's a crucial distinction right from the start. The elbow isn't one joint. It's a sophisticated complex. It incorporates three distinct articulations, all housed within a single shared joint capsule. Think of it like a meticulously designed biomechanical puzzle. You have the ulnohumeral joint, it's the primary hinge, allows flexion and extension. Then there's the radiocapitellar joint, so radial head meeting the capitellum. That allows flexion and extension, but also plays a vital role in forearm rotation. And finally, the proximal radial ulnar joint, purely dedicated to forearm rotation, pronation, and supination.
Right.
This intricate interplay, that's what allows both sagittal plane movements, bending and straightening, and also that vital coronal plane rotation of the forearm. It's the crucial connection, isn't it, between the shoulder and the hand, allowing us to position the hand precisely in three-dimensional space, whether you're lifting something heavy, throwing a ball, or manipulating a small instrument with precision. This combination, changing the upper limb's length and altering hand position, that's what makes it so functionally important in almost every daily activity.
That three joints in one concept really does highlight its complexity. Let's focus on the distal humerus first then. That forms the proximal anchor of the system. What are its unique anatomical features that really define the elbow's motion and its stability?
The distal humerus. It's quite fascinating, actually. It presents some subtle yet critical features that, well, they often go overlooked until you're deep into surgical planning. While it might look relatively straight in the coronal plane, viewing it from the front,
Yes.
it actually possesses an approximately 10-degree apex posterior bow in the sagittal plane, so viewed from the side.
Okay, a slight curve backwards.
Precisely. And this isn't just a trivial anatomical detail. From a surgical perspective, this posterior bow significantly influences your approach, especially if you're considering, say, the trajectory for intramedullary nailing. Ignore it, and you can end up with malalignment or inadequate fixation. Internally, the bones canal itself isn't uniform either. It evolves from a circular shape more proximally up in the shaft to a distinctly triangular shape as it flares out distally. And as it widens at the end, it forms those distinct medial and lateral columns, each with its own role. The lateral column gives rise to the capitellum, that's positioned more laterally, and it diverges more acutely from the humeral shaft than the medial column does. This medial column, in turn, forms the trochlea.
The school-shaped bit.
Exactly, the spool-shaped trochlea, which is arguably the cornerstone of the ulnohumeral articulation. It's perfectly centered over the distal humerus, aligned with the humeral shaft's long axis. If you look closely at the trochlea, you'll see it has two well-marked borders, a prominent medial ridge, and a slightly smaller lateral ridge, separated by the trochlear groove, that central sulcus. These features form, on average, a 142-degree open angle. We call it the trochlear notch angle.
142 degrees.
Yes, and this specific angle is absolutely critical for articulating precisely with the ulna, ensuring proper engagement of the coronoid process. The apex of the coronoid's medial and lateral faces sort of keys into this notch. It provides a significant aspect of inherent bony stability.
So any disruption there, like a fracture.
Immediately leads to instability, yes.
Yeah.
The capitellum, on the other hand, it's often shown as a perfect sphere in diagrams, but it isn't truly spherical. It's
Oh.
actually ellipsoidal. It has a greater radius of curvature in the medial lateral direction compared to the anterior posterior.
Hmm.
This non-spherical shape has profound implications for how it articulates with the radial head. It influences the natural biomechanics and, critically, dictates the design of any radial head prostheses.
Right, because replacing it with a sphere wouldn't match.
Exactly. Trying to replace an ellipsoidal surface with a perfectly spherical implant can lead to abnormal contact pressures,
Well,
altered kinematics, and potentially long-term issues like pain or accelerated wear. And then there's the carrying angle, a classic clinical sign.
yes.
Crucially, the medial ridge of the trochlea is more prominent than the lateral. This leads to a consistent 6 to 8 degree valgus tilt at its articulation with the ulna.
So it angles outwards slightly.
Precisely. This tilt contributes significantly to what we call the carrying angle of the elbow, the angle formed between the long axis of the humerus and the long axis of the ulna. This angle typically measures around 10-15 degrees in males and a bit more, 15-20 degrees, in females. It's subtle but profoundly important. It allows the forearm and hand to clear the hip during walking, and functionally, it lets us carry objects away from the body without them bumping into our torso.
Makes sense.
Furthermore, the capitellum itself is flexed forward by about 40 degrees in the sagittal plane.
40 degrees. Wow.
Yes, which means the actual flexion-extension axis of the elbow isn't perfectly parallel to the coronal plane. It's internally rotated by about 14 degrees. This rotational difference explains why the carrying angle appears to change as the elbow moves from flexion into extension. It can be a bit confusing initially.
I can see that.
So for us as orthopedic surgeons, understanding this means we rely on a practical guide, the transepicondylar axis. This axis, connecting the medial and lateral epicondyles, serves as a remarkably useful approximation for the true flexion-extension axis. It helps us get accurate alignment during complex procedures, especially fracture fixation or arthroplasty.
That provides such a clear picture of how the humerus really sets the stage for motion. But now, moving down, the proximal ulna that articulates directly with the humerus, it brings its own set of fascinating complexities, doesn't it? What should our listeners know about its intricate, sort of three-dimensional angulations?
It certainly does. The proximal ulna is, yes, a marvel of complex 3D geometry, which is absolutely vital for elbow stability and for managing challenging things like Monteggia fracture dislocations or transolecranon fracture dislocations. When you look at it, you immediately notice distinct dorsal, varus, and torsional angulations, each with profound clinical significance. Understanding these subtle bends is key to avoiding pitfalls in surgery.
Okay, let's break those down. Dorsal first.
Right, the proximal ulnar dorsal angulation, or PUDO. This is a consistent feature seen in over 95% of studies, Caucasian cadavers typically. It averages around 5 to 6 degrees, though there's quite a bit of natural variation person to person, ranges from almost flat to nearly 12 degrees.
And where is that bend located?
Typically located roughly 4.5 to 5 centimeters distal to the olecranon tip. Now, what's truly fascinating here, and critically important for patient outcomes, is its direct correlation with the elbow's range of motion. We've seen that elbows with the smaller PDA, specifically less than about 5 degrees, tend to have significantly greater terminal extension.
That are straightening.
Exactly, which is a key functional outcome. Though terminal flexion seems similar, it suggests that even subtle variations, just a few degrees of angulation, can influence how far a patient can straighten their arm post-injury or post-surgery. It's a reminder that every degree matters, doesn't it? Especially in the elbow.
Definitely. Okay, what about the varus angulation?
The proximal ulna also has a subtle varus angulation. The apex points radially outwards. This typically ranges from 4 to 15 degrees, average around 9 degrees perhaps in various studies. The point of this angulation is often around 7 to 8.5 centimeters from the olecranon tip.
So further down than the dorsal bend?
A bit further down, yes.
Okay.
It's often simplified in clinical lore. Mark Maury's figures, for instance, as the rule of 8, roughly 8 degrees of radial bow, about 8 centimeters from the olecranon tip.
The rule of 8. That's handy.
It is. And if we connect this to the bigger picture for surgeons, the location of this varus angulation has very practical implications. For procedures like tension band wiring for olecranon fractures, imagine you're trying to compress a fracture. If your distal hole for the wire is placed too far distally beyond this apex.
Beyond the 8 centimeter mark.
Yes, it can create a displacing sliding force. rather than a straight compressive pull along the bone's axis. So your fixation, instead of stabilizing, could actually be pushing the fragments apart.
Oh dear.
Exactly. This strongly suggests a critical window for distal fixation. Ideally, not more than 7-8 centimeters from the olecranon tip to ensure optimal biomechanical force transmission. Avoid that iatrogenic displacement. It's a classic example, really, of anatomy directly informing technique.
Absolutely crucial. And the torsional angle.
Yes, beyond the sagittal and coronal planes, the olecranon is also externally rotated relative to the discal ulnar shaft. This forms a torsional angle. It can range quite a bit, 11 to over 20 degrees. This complex twist plays a vital role in how the forearm rotates, contributing to pronation and supination kinematics.
So a malunion there could really limit rotation.
Severely, impacting daily tasks significantly. And then we have to consider the internal features of the olecranon itself. There's a distinct bare area lacking articular cartilage, typically about half a centimeter wide.
The bare area.
Yes, often overlooked.
Yeah.
But here's where it gets critical. During fracture reduction, especially complex interarticular fractures, there's a strong temptation to overcompress this bare area, trying to get that perfect articular reduction.
All right, you want it smooth.
But inadvertently, this can lead to a narrowed trochlear fossa, an incongruent radius of curvature between the ulna and humerus. The long-term impact: increased joint stiffness, altered kinematics, higher risk of post-traumatic arthritis. It's a delicate balance, isn't it? Perfect reduction versus preserving overall joint mechanics. Furthermore, the medullary canal of the ulna, it isn't uniformly circular. It's elliptical and it tapers. Its narrowest point is typically just after the midshaft, averaging about 4 millimeters in diameter.
Elliptical and tapering.
Exactly. Understanding these precise dimensions is crucial for intramedullary nailing. Dictates implant size, shape, insertion trajectory, averted cortical impingement, or malrotation.
That's incredibly detailed, and the clinical implications you're highlighting really drive home why these nuances matter so much. Now, shifting to its functional role in stability, the coronoid process, it's often highlighted as being especially important, almost like a central pillar. Could you elaborate on its significance? Why is it considered such valuable real estate in the elbow?
The coronoid. Yes, it's often described as the most valuable piece of real estate in the elbow, and for very good reason. Along with the olecranon, it forms the greater sigmoid notch of the ulna, which articulates directly, intimately, with the humerus's trochlea. This deep, bony articulation, almost like a mortise and tenon joint, provides a significant degree of inherent bony stability, resisting both anterior and posterior displacement.
So the shape itself provides stability.
A great deal of it, yes. When we consider the combined role of olecranon and coronoid, the olecranon acts as that critical bony block, preventing excessive anterior translation of the ulna, especially in extension. Studies have shown, for instance, removing more than 25% of the proximal olecranon can lead to measurable instability during varus rotational stress.
Just 25%.
Yes, and if you remove 50%, you're looking at a significant, often catastrophic loss of stability against anterior or volar displacement of the ulna. It highlights its substantial contribution as a primary bony constraint. But the coronoid process itself, that triangular bone arising from the anterior proximal ulna, I call it the ultimate anchor point for critical soft tissues.
The anchor point.
Yes. Medially, you have the sublime tubercle. That's the crucial distal attachment site for the anterior bundle of the medial collateral ligament, the primary valgus stabilizer. Laterally, it hosts the lesser sigmoid notch, articulating with the radial head, and immediately inferior and distal to that, the supinator crest, where the lateral collateral ligament complex attaches. So both MCL and LCL complexes attach there. Converging on this relatively small bony prominence, yes, this makes the coronoid absolutely fundamental to the elbow's overall stability. It anchors the entire joint capsule and both crucial collateral ligament systems. Given its critical role, it's no surprise that coronoid fractures are rarely isolated. They're often considered pathognomonic for an episode of elbow instability.
So if you see one, you think instability.
Immediately. Your first thought should be, look for associated ligamentous injuries, especially dislocations. They are commonly associated with ligamentous injuries, and they're a key component of the infamous terrible triad.
Ah, yes, the terrible triad: dislocation, radial head fracture, coronoid fracture.
Exactly. Our understanding of these fractures has evolved significantly with better imaging, better biomechanical studies. For example, we now know large coronoid fractures are often linked to anterior and posterior olecranon fracture dislocations. The olecranon acts as a lever against the trochlea. In contrast, small transverse fractures are typically seen in terrible triad injuries due to shear forces. And anteromedial facet fractures are specifically associated with varus posteromedial rotational instability patterns, often caused by an axial load with a varus moment and supination.
So the fracture pattern tells you about the injury mechanism.
Precisely. This morphological understanding, classifications like O'Driscoll's, it guides our management strategies directly. Now, a critical nuance that informs surgical decision-making is understanding the soft tissue attachments. The very tip of the coronoid, well, interarticular, doesn't actually have significant soft tissue attachments.
The tip itself is relatively free.
Relatively free, yes. This means fractures of the tip involving less than 2 millimeters. O'Driscoll type 1 may not need fixation if the elbow remains stable after reduction. They don't involve those crucial capsular or ligamentous attachment points.
That's okay.
However, larger tip fractures, O'Driscoll type 2, involving over 2 millimeters, and basilar fractures, involving at least 50% of the coronoid height and including a broader capsular attachment. They absolutely require careful repair to restore that vital stability. Ignoring them is just inviting persistent instability.
That makes sense. Fix what's holding the ligaments.
Exactly. And what's also truly fascinating here, speaking to the sophistication beyond just mechanics, is the neuroanatomy, the sensory receptors. Dense, slow-adapting Ruffini corpuscles, detecting sustained pressure, and fast-acting Pacinian corpuscles, sensing vibration and rapid changes. They're found mainly in the anterior elbow capsule, including its attachment to the coronoid.
So the capsule is full of sensors.
Richly innervated. These mechanoreceptors detect subtle changes in joint pressure and modulate muscle reflexes. They play a vital role in neuromodulation of elbow joint stability. It means the brain is constantly getting feedback, allowing dynamic protective mechanisms through muscle contraction, even before you're consciously aware of a problem. It's like a proprioceptive superpower for the elbow.
Incredible.
And from a reconstructive perspective, especially for comminuted coronoid fractures where bone stock is severely deficient, the tip of the ipsilateral olecranon has been shown to be an incredibly effective autograft.
Using bone from the olecranon itself.
Yes. Cadaveric models of significant coronoid deficiency, where up to 40% was removed, demonstrated that reconstructing with this graft effectively restored normal kinematics over a functional range, 20 to 120 degrees. It provides a valuable, accessible surgical option for restoring critical bony architecture and, consequently, global elbow stability. Truly transformative for patients with devastating injuries.
That's an incredibly comprehensive look at the ulna and coronoid. Now, the radial head often gets overshadowed by the coronoid, perhaps seen as less critical, but it also appears to be a crucial player, especially for specific types of stress. What should our listeners know about its anatomy and how it contributes?
You're absolutely right to highlight the radial head. While it is often labeled a secondary valgus stabilizer, its importance can easily be underestimated, and in certain situations, its role becomes absolutely primary. It contributes about 30% of the elbow's overall valgus stability.
30% is significant.
It is. And this contribution is particularly critical at lower degrees of flexion, 0 to 30 degrees specifically, and in pronation. That's where it acts as a significant buttress against outward bending forces. Its anatomy is quite complex, much more so than its simple head designation suggests, while often depicted as circular in diagrams.
Like the capitellum, it isn't quite circular.
Exactly. It's described as ellipsoidal. Furthermore, it has a subtle 1 to 2 millimeter depression in the middle of its proximal articular surface, known as the dish or the fovea radialis. This fovea is circular, but importantly, it's offset from the geometric center of the overall radial head circumference.
Offset. Why is that important?
This seemingly minor offset is crucial for how it articulates with the convex capitellum proximally and the lesser sigmoid notch of the ulna medially. It allows for complex motion, including both rotation and translation. Trying to replace this with a perfectly circular implant, as we discussed with the capitellum, often creates abnormal contact stresses and impingement, leads to pain, reduced function over time. About 2/3 of the radial head circumference is covered by thickened articular cartilage, the articulating surface.
Okay.
However, the remaining third, roughly 113 degrees, is non-articulating. Thinner cartilage. This non-articulating portion, which aligns with external landmarks like the radial styloid and Lister's tubercle.
Ah, the safe zone for screws.
Precisely. That's where surgeons can safely place screws for internal fixation of radial head fractures without compromising the crucial articular surface. If you inadvertently put a screw into the articulating part, you risk an intra-articular step-off, leading to painful impingement, cartilage wear, early arthritis. Also, the bicipital tuberosity, where the biceps tendon inserts, is also offset from the radial head, situated opposite this non-articular portion.
Got it. And biomechanically, how does it work?
In terms of biomechanics, rotation, and stability, the concave proximal surface of the radial head essentially acts as a buttress against the convex capitellum. This concavity compression mechanism, where compression across a convex joint enhances stability along with tensioning of the lateral collateral ligament complex, helps resist external rotation at the ulnar humeral joint. What's even more intriguing is the non-circular nature, meaning it doesn't rotate precisely around a fixed center. Instead, with pronation, the radial head translates slightly anteriorly. This puts tension on the posterior annular
That's
ligament.
supination.
Conversely, in supination, it translates posteriorly, tensioning the anterior part of the annular ligament. Altering this native offset, say, with a perfectly circular radial head replacement, has been shown in studies to significantly affect the axial rotation of the ulna during flexion extension and its rotation during gravity valgus stress. Leads to abnormal kinematics, potentially persistent symptoms.
So preserving or replicating that offset is key.
Absolute key. The radial head's role becomes even more pronounced when the medial collateral ligament, the primary valgus stabilizer, is deficient. In devastating injuries like a terrible triad, where the MCL is ruptured, radial head replacement has been shown to restore valgus stability to levels remarkably similar to an intact elbow.
Really? Even without fixing the MCL?
It provides significant stability, yes. But it's important to note, complete valgus stability isn't usually fully restored until the MCL is also repaired or reconstructed. It demonstrates that crucial interplay of primary and secondary stabilizers working together. And here's where our understanding has truly evolved, challenging traditional thinking.
How so?
Early studies, particularly focusing on acute injuries, suggested that with an intact MCL, the radial head could be safely excised without significantly altering elbow biomechanics. This led to a belief that the radial head was somewhat dispensable if the MCL was okay.
I remember that teaching.
Exactly. But more recent research, with longer-term follow-up, more sensitive biomechanical testing, has directly challenged this. It has definitively demonstrated that isolated radial head excision, even with an intact MCL, can lead to posterolateral rotatory instability.
Even if the MCL is fine?
Yes. Possibly due to decreased tension in the LCL complex, which forms that hammock around the radial head. Furthermore, excision also increases valgus laxity across the elbow, regardless of whether the collateral ligaments are intact or not. This raises a critical question about its dispensability. It strongly advocates for preservation or careful anatomical replacement when injured. Its long-term absence can lead to chronic instability and pain.
That's a significant shift in thinking.
It absolutely is, and it has transformed our surgical algorithms.
That's a powerful insight, especially regarding the evolving understanding of the radial head. So if the bones are the foundation and the radial head is a critical pillar, how do the soft tissues, particularly the ligaments and the joint capsule, collectively form what some call a fortress of static constraints? What are the key elements of this fortress?
That's an excellent analogy. A fortress of stability is precisely what these structures provide. The inherent bony congruence we've discussed works hand in hand with the capsule ligamentous structures, creates those robust static constraints essential for function and resisting injury. Let's start with the joint capsule. The elbow joint is enveloped in a robust fibrous capsule. It's not just a simple sleeve. It extends quite proximally, encompassing the radial and coronoid fossa anteriorly and the olecranon fossa posteriorly. Forms deep recesses for the bony prominences during full motion.
So it gives space for movement.
Exactly. It then attaches distally to the coronoid's anterior margin, the annular ligament, and the articular margin of the sigmoid notch. The capsule itself has distinct fibrous bands, particularly anteriorly. Anterolateral, anteromedial, anterior transverse bands. These different fiber orientations suggest an important role, though still being fully defined, in joint strain and stability under various loads. Biomechanically, the capsule becomes taut anteriorly in full extension, resisting hyperextension, taut posteriorly in full flexion.
So it tightens at the extremes of motion.
Yes, and it actually contributes most to overall stability when the elbow is extended, acts as a significant check rein. Notably, intra-articular pressure is lowest at 70 to 80 degrees of flexion. That's often called the position of comfort for an injured elbow.
Ah, where patients tend to hold their arm.
Precisely. And its capacity, when fully distended, can reach 25 to 30 milliliters at 80 degrees of flexion. This lowest pressure point has implications for patients with effusions, and it's key for procedures like arthrocentesis.
Makes sense. Now the ligaments, the MCL complex.
Right, the medial collateral ligament, or MCL complex, classified as a primary stabilizer. It's particularly critical against valgus and posteromedial rotational stresses. Essentially prevents the elbow opening up on the inside. It's composed of three distinct components: the anterior bundle, the posterior bundle, and the transverse ligament, also known as Cooper's ligament. The anterior bundle is, without doubt, the most critical component. Originates from the anteroinferior surface of the medial epicondyle, inserts onto the sublime tubercle of the coronoid.
Onto the coronoid again.
Yes. Makes it the most important restraint against valgus forces. Bears the brunt of valgus stress, especially during overhead activities like throwing, where forces can be enormous. The posterior bundle forms the floor of the cubital tunnel. Serves as a primary restraint to valgus stress in maximal elbow flexion. If contracted or scarred, it can significantly limit terminal flexion. The transverse ligament, horizontally oriented fibers between olecranon and coronoid, generally not believed to contribute significantly to stability. Its role is mainly deepening the trochlear notch.
So the anterior bundle is a main player medially.
Absolutely. And what's truly fascinating here, essential for surgeons reconstructing it, is how its tension changes through motion. Its origin on the medial epicondyle is slightly posterior to the elbow's flexion axis. This creates a cam-like effect. The anterior bundle's overall length increases by about 18% from full extension to 120 degrees of flexion.
It gets longer as you bend.
Overall, yes. However, more nuanced research highlights a specific central band within the anterior bundle. This central band has its proximal origin exceptionally close to the axis of rotation of the ulnohumeral joint.
Right on the axis.
Very close. This unique alignment makes it nearly isometric, meaning its length remains relatively constant, taut throughout the full arc of flexion, essentially acts as a guiding band. Sectioning this central band alone leads to significant valgus instability, even if other parts of the MCL are intact, underscores its pivotal role.
Wow.
And the good news is its single-strand reconstruction has been shown to effectively restore valgus stability to near-intact levels. A powerful finding for surgical reconstruction, especially in throwing athletes or after dislocations.
That's great to know. What about the lateral side, the LCL complex?
On the lateral side, we have the lateral collateral ligament, or LCL complex. This is the primary restraint against external rotation and varus stress. Prevents the humerus rotating externally on the ulna, resists inward bending. It comprises four components: the radiocollateral ligament, the lateral ulnar collateral ligament, LUCL, the annular ligament, and the accessory collateral ligament. The LUCL is particularly important in this complex, originates from the lateral epicondyle, inserts into the supinator crest, forms a critical hammock-like structure behind the radial head.
A hammock?
Yes. This unique configuration is what makes it so crucial for preventing varus and posterolateral rotatory instability, a common and debilitating pattern of instability. Unlike the MCL, the LCL's origin on the lateral epicondyle is remarkably well aligned with the elbow's flexion axis, ensures uniform tension throughout the arc of motion.
So it's always tight, regardless of flexion angle.
It maintains its stabilizing role consistently, yes. Whether the arm is straight or fully bent, this raises an important question. How integrated is this complex? Recent research strongly suggests the LCL complex functions much more as a single unit, a functional continuum, rather than each part having its own distinct stabilizing function. Minor laxity occurs if the annular or LUCL are cut in isolation. However, here's the clinical pearl.
Yes.
If the annular ligament wrapping around the radial head remains intact, both the radial collateral and lateral ulnar collateral ligaments need to be transected to produce significant posterolateral, rotatory, and varus valgus instability.
So the annular ligament is key to the whole complex.
It seems to be the linchpin. This has significant implications for lateral surgical approaches. It tells us that as long as the annular ligament is carefully preserved during an approach, individual cuts to the radial collateral or LUCL can be made and then precisely repaired without causing significant long-term instability.
But that gives surgeons a safety margin.
A critical margin of safety and flexibility during exposure, yes, allows access to deeper structures while maintaining the overall integrity of the lateral complex.
So we've covered the impressive static stabilizers, this fortress of bones and ligaments. But the elbow is a joint of constant dynamic motion. The muscles must play an equally significant role. Could you explain how muscles contribute to this fortress, how they protect the static structures, especially during high-demand activities?
Precisely. While the static constraints provide the fundamental architecture, muscles crossing the elbow joint act as crucial dynamic stabilizers, primarily by applying a compressive load across the joint when they contract. This compression, often under very high forces, helps protect and unload those static soft tissue constraints, especially during explosive high-demand activities.
Like throwing.
Exactly. Consider throwing a baseball or even a heavy object. The valgus stress generated at the elbow can actually exceed the failure strength of the MCL. literally tear it apart. However, the flexor pronator muscle group, primarily pronator teres, flexor carpi radialis, palmaris longus, contracts powerfully during this motion. This muscle contraction provides massive dynamic medial stability. It effectively protects the MCL from injury by offloading some of that valgus stress.
So the muscles take some of the strain off the ligament.
A significant amount. It highlights how dynamic muscle action is absolutely essential for preventing devastating injury during high-load activities, particularly in elite athletes. In biomechanical studies, loading these muscles on an unstable elbow has been shown to dramatically decrease the variability of motion pathways of the articulating surfaces and significantly increase overall joint constraint. It's a testament to the body's incredible adaptive capacity. Dynamic forces compensating for structural limitations.
Fascinating. And the kinematics, the actual movement and forces.
Right, kinematics and joint forces. The elbow's primary movements are flexion and extension, occurring around an axis centered at the trochlea. But it's not just a simple hinge. Forearm pronation and supination occur at the radiocapitellar and proximal radial venar joints. They happen around an axis that effectively forms a cone, from the capitellum through the radial and ulnar heads. What's truly fascinating here, critical for understanding subtle impingement or ballooning issues, is that the axis of forearm rotation isn't perfectly fixed.
It moves.
It shifts slightly. Ulnar and volar during supination, radial and dorsal during pronation. The radius itself also moved proximally with pronation and distally with supination. It's an intricate, coordinated ballet, this multi-joint complex.
Wow.
Any disruption to the subtle translation can lead to significant loss of forearm rotation or painful impingement. Now, regarding joint forces, it's a common misconception, particularly outside orthopedics, to think of the elbow as non-weight-bearing, largely protected from high loads.
But that's wrong.
Completely erroneous. Forces across the elbow are significant, far exceeding what many might assume in daily life. For instance, a simple fall into an outstretched hand from just 6 centimeters a couple of inches can generate an axial compression force equivalent to 50% of body weight across the elbow joint.
Half your body weight from a tiny fall.
Exactly. And something as common as performing push-ups creates an average force of 45% of body weight across the joint. Even lifting a coffee cup generates significant forces. These are substantial loads the elbow must repeatedly withstand. And these loads aren't evenly distributed either. Approximately 43% of the axial load passes through the ulnohumeral joint, a slightly greater 57% through the radiocapitellar joint, particularly at 0-30 degrees flexion and in pronation, when the radial head is acting most as a buttress.
So more goes through the radial side?
In certain positions, yes. The force concentration also shifts with elbow position. When the elbow is extended, the force on the ulnohumeral joint is more concentrated at the coronoid, the first point of contact. But as the elbow flexes, that force gradually moves posteriorly towards the ulcanon.
Which explains some fracture patterns.
Precisely. This dynamic shift has direct implications for understanding fracture patterns. Coronoid fractures often result from shear forces from axial loading and extension. Olecranon fractures typically from axial loading and flexion. Understanding these force dynamics is absolutely critical for injury prevention, accurate diagnosis, precise surgical planning, allows us to anticipate injury patterns and design appropriate fixation.
That detailed understanding of anatomy and biomechanics clearly underpins our entire approach to elbow pathology. It's not just academic, is it? It directly informs clinical decisions. Could you discuss some of the most common elbow injuries we see in clinical practice and how this knowledge really guides us in diagnosis and treatment?
Absolutely. Connecting these intricate principles to real-world clinical practice is where the true value lies. Understanding these concepts is vital for competent diagnosis and treatment of elbow injuries, and they are frequently encountered in orthopedic practice across all age groups. Let's start with fractures and dislocations. Elbow fractures are particularly common, especially in children. Count for about 10% of all childhood fractures. Often at the distal humerus or radial head falls onto an outstretched hand.
The classic Fuchs injury.
Exactly. While many simple fractures can be managed non-operatively, a thorough understanding of the joint's unique biomechanics ensures we consider not just bone healing, but meticulous restoration of joint congruity and stability. Remember, the ulnohumeral joint alone contributes as much as 50% to the elbow's overall stability. Any malalignment there can have profound consequences. Elbow dislocations, often from direct blows or accidents, present with clear misalignment, often severe pain. While many simple dislocations become relatively stable once reduced, surprisingly, despite near-universal MCL rupture and frequent LCL disruption, initial management must go beyond just relocating the joint.
You need to look deeper.
Meticulously. Address potential associated injuries to ligaments or nerves. As seen in the dreaded terrible triad injuries dislocation with radial head and core node fractures, these cases underscore the paramount need to assess the entire fortress of stability, not just the obvious displacement, because if any key elements are compromised, the elbow will remain chronically unstable.
Right. What about sprains and tendon issues?
Common sprains involve damage to ligaments, like the MCL, often from sudden impacts, or, more frequently, repetitive valgus stress, particularly prevalent in throwing athletes. Think of professional baseball pitchers.
Chronic stress.
Exactly. Then there are the ubiquitous tendon injuries, lateral epicondylitis, tennis elbow, pain on the outside, affecting the common extensor origin where wrist extensors attach. Conversely, medial epicondylitis, golfer's elbow, affects the inside at the common flexor pronator origin pronator teres, flexor carpi radialis.
Very common presentations.
Classic examples of overuse syndromes, where understanding the specific muscle attachments, their biomechanical stresses, the exact points of origin and insertion, it's paramount for effective diagnosis, targeted treatment, successful rehab. Moving beyond just symptomatic relief to address the underlying cause. Other common conditions include olecranon bursitis, inflammation of the fluid-filled sac at the elbow tip.
The goose egg.
Often described that way, yes. Results from repetitive motion, direct trauma or infection. Presents with redness, swelling, pain. Another frequent one is cubital tunnel syndrome. Compression of the ulnar nerve as it runs through that narrow, vulnerable space at the elbow, the cubital tunnel, bounded by medial epicondyle, olecranon, arcuate ligament.
Causing numbness and tingling.
Exactly, often in the arm and hand, exacerbated by frequent elbow bending or direct injury. In both bursitis and cubital tunnel syndrome, precise anatomical knowledge guides conservative management and, if needed, surgical intervention to relieve symptoms and restore function, whether draining a bursa or decompressing a nerve.
Given this whole array of injuries and conditions, what's the gold standard for clinical assessment and diagnosis? How do you piece together all this knowledge to arrive at an accurate conclusion for your patients?
A comprehensive clinical assessment is always the gold standard, always the starting point, building logically from the patient's story to targeted physical findings, and finally, judicious use of imaging. The physical examination begins with a detailed patient history, focusing intensely on symptoms, onset, aggravating relieving factors, patient's engagement at sports, work, repetitive movements, helps narrow the differential diagnosis significantly.
The history is key.
Absolutely. The physical exam itself involves a systematic approach, checking active and passive range of motion, carefully comparing the injured elbow to the contralateral side, muscle bulk, appearance, subtle asymmetries. We perform specific provocative maneuvers, applying direct pressure to tender areas to pinpoint the pain source. A valgus stress test, for example, is critical for replicating throwing stresses, identifying potential MCL instability or looseness. Crucially, the patient's shoulder and wrist should also be thoroughly evaluated if necessary. Elbow and shoulder mechanics are intimately linked. Referred pain-associated injuries are common.
Good point about checking adjacent joints. And imaging.
To support clinical findings, we often rely on imaging, but always with a specific question in mind. X-rays are foundational. Visualizing bone, identifying fractures, stress changes like bone spurs, often multiple views, AP, lateral, obliques to fully delineate bony anatomy. Magnetic resonance imaging, MRI, offers unparalleled detail of soft tissues, allows us to differentiate ligament and tendon disorders, assess injury severity, identify cartilage damage, detect occult fractures.
When would you use an arthrogram?
In cases where further detail on ligament integrity is needed, especially for subtle tears, an arthrogram contrast injected into the joint before MRI may be performed to assess for full-thickness tears. Less common for routine elbow issues in throwing athletes, but computed tomography, CT scans, are invaluable for defining complex bony structures and intricate fracture patterns, especially those with a multiplanar involvement or significant comminution, often missed on plain radiographs.
So imaging supports the clinical picture.
Ultimately, yes. The diagnosis of specific conditions like lateral elbow tendinopathy often relies heavily on the clinical findings. Pain, precisely reproduced by pinpoint pressure on common extensor tendons, discomfort during specific loading activities like gripping, rather than solely on imaging. Unless there are clear indications of associated fractures, significant instability, or failure of conservative management. Same applies to golfer's elbow. Detailed symptom discussion, physical examination remain the crucial elements for accurate diagnosis. Highlights the primacy of the direct clinical encounter over reliance on technology alone.
Prof, that has been an incredibly insightful deep dive into the elbow. We've traversed its intricate bony architecture, delved into the crucial roles of ligaments and capsule, explored the dynamic contributions of musculature, and connected all of this to common clinical presentations and diagnostic approaches. It's truly a testament to how complex these seemingly simple movements are, how every degree of angulation, every slight shift in force distribution can have profound clinical significance.
Indeed. Our advancements in anatomical and biomechanical understanding over recent decades have fundamentally transformed surgical reconstruction and fracture fixation techniques, allowing us to restore function more effectively for our patients than ever before. The elbow is a primary example where meticulous anatomical knowledge, coupled with understanding biomechanical forces, directly translates into improved surgical outcomes and enhanced patient care. It's an exciting time, really, to be an orthopedic surgeon focusing on this joint.
Here's where it gets really interesting and maybe something for you, our listeners, to mull over. As our understanding of that neural feedback from the capsule, those Ruffini and Pacinian corpuscles we discussed, and the intricate interplay of dynamic muscle compression continues to deepen, how will this knowledge further refine our rehabilitation protocols and preventative strategies,
Hmm.
especially for elite athletes? What new frontiers will this open in optimizing performance and preventing re-injury? That's certainly something to ponder as you continue your clinical journey. Thank you so much for sharing your profound expertise with us today.
My pleasure entirely.
To our listeners, we hope this deep dive has provided you with valuable insights that will truly enhance your practice. If you found this discussion beneficial, please take a moment to rate and share the Deep Dive Ortho with your colleagues. It really helps us reach more professionals like you. Until next time, keep delving deeper.